Let's get started. Good evening, everybody. My name is Alexa Schafer, and I am an academic advisor in the College of Liberal Arts and Sciences Academic Advising Center at Grand Valley. And my colleague, Brandon Moskin, who you probably saw on the way in here, he and I are happy to welcome you all. This particular building that we're in is GVSU's newest building, the Daniel and Pamela DeVos Center for Interprofessional Health. This building opened in May of 2021, and it's the third GVSU building on the Grand Rapids Medical Mile and features classrooms and interactive laboratories equipped to create interprofessional team environments and encourage collaboration among health profession students. Tonight's event, the Your Health Lecture Series, is a unique educational partnership between Grand Valley State University, Grand Rapids Community College, and Michigan State University College of Human Medicine. The goal of the series is to feature physicians and researchers who can speak on a wide variety of topics of interest to public audiences. Earlier this evening, tonight's guests met with pre-med students from GVSU and GRCC. The pre-med students here had an opportunity to meet with our medical students and have roundtable discussions and also hear from them on a panel. I'd like now to introduce Mark Breavy, Director of Community and Government Relations for Michigan State University's College of Human Medicine.
Thanks, Alexis. And I do want to thank Grand Valley State University for hosting this event in this great facility. This lecture would not be possible without the co-sponsors of the event, Grand Valley State University, Grand Rapids Community College, and Michigan State University College of Human Medicine. This is the 11th year of the Your Health Lecture Series event at Grand Valley State University and the 10th year of this partnership with Grand Rapids Community College. This year, as we did last year, we combined our efforts into one event due to the unique partnership we have through the Early Assurance Program agreement between our three schools. GVSU and GRCC students are eligible for early admission to medical school through this program. GRCC students have pathways to the College of Human Medicine, both through Grand Valley State University and Michigan State University undergrad. Now, without further ado, I would like to introduce our speakers for this evening. Beth Makowski, DO, is the Medical Director of MSU Grand Rapids Street Medicine, core clinical faculty in the Department of Internal Medicine at Michigan State University College of Human Medicine, and Division Chief of Acute Care Medicine at Corewell Health in Grand Rapids. Dr. Makowski is board certified in internal medicine. She's a graduate of Michigan State University with a Bachelor of Science in Physiology in 2003 and earned her Doctor of Osteopathic Medicine from Michigan State University College of Osteopathic Medicine in 2007, and she completed her residency in internal medicine from Metro Health Hospital in 2010. Christa Schafer Newtile received her Bachelor of Science in Neuroscience from the University of Michigan, Ann Arbor. We won't hold that against her. She is currently a fourth-year medical student at Michigan State University College of Human Medicine, so she knows how to make a good choice in life. That's good. She is pursuing her residency in pediatrics, where she plans to continue advocating for underserved populations and the effects of adverse childhood experiences on health. Victoria Moaddel received a sociology degree from the University of Michigan, again in 2014, and completed her pre-medical sciences at Grand Valley State University. So again, she showed great, anyway, in 2017. She is currently a fourth-year medical student at MSU College of Human Medicine, pursuing an emergency medicine residency and hopes to continue to use her experience with Grand Rapids Street Medicine to shape her approach with unhoused patients in the emergency department. With that, I'm going to turn it over to our presenters, starting with Dr. Makowski.
Thank you. I'll try not to break any of the technology here. I know that this isn't transmitting in the room. If you guys can't hear me, let me know, but this is for the audience online. Awesome. Okay. Here we go. So Christa, Victoria, and myself, we're going to talk about street medicine caring for the unsheltered. And we're going to go through a couple of important things that we really want to focus on. We want to talk about the foundation for understanding facts about the unsheltered community, both across the nation and here in Grand Rapids. We want to talk about those experiencing homelessness and the impact that that has on their health. And then Christa and Victoria are going to talk a lot about The organization that we work with is Grand Rapids Street Medicine, but in general, street medicine here in Grand Rapids and collaborative efforts citywide to bring care to our community members that are experiencing homelessness. So I'm not going to make you participate. I hate group participation in situations like this, so I'm not going to do that to you, but just something to think on. So if anyone has any kind of idea, where do you think, how many people are estimated to be experiencing homelessness at any one time in the US? And would you be surprised to find out that it really is 18 in 10,000? This information comes from the HUD's annual homelessness assessment report. And so they do a point in time assessment on a single night. It's usually in January, I believe, where they count how many people are experiencing homelessness across the United States to the best of their ability. And so we're currently sitting at about 18 per 10,000, and that number has been increasing. We've seen reductions in homelessness across the US up until 2016. And then we've seen increases consecutively in the last 6 years, an overall increase of 6% since 2016. The increase is largely impacted by individuals who are experiencing chronic homelessness. And so that's homelessness that is lasting greater than 1 year. And we've seen a 15% increase in this since 2019. So here's a nice chart. I really like this one to show kind of what's been happening in the US with homelessness. Since 2007, you can see kind of where we started at that top line, dropped off a little bit. And then in 2016, we started to climb back up. You can see the numbers of individuals experiencing homelessness, how men outnumber women. The homelessness for women has been pretty flat across the US, but that unsheltered population is really increasing, as are people and families. We did expect a bigger jump during the pandemic. Fortunately, we didn't see that. And we expected that due to just increasing trends in unemployment and then increasing healthcare costs for a lot of people across the United States. And we think that it did not get as worse as we were worried that it was going to get, just because some of the public policy that was put in by the government, moratorium on evictions and those sorts of things. Here in Kent County and Grand Rapids, the Coalition to End Homelessness also tracks local numbers about those experiencing homelessness. And you can see that we have an increasing trend since 2018. We do see in Grand Rapids that we actually have a little bit of a drop off in number of unsheltered individuals experiencing homelessness. So more of the community members experiencing homelessness here in Grand Rapids are actually seeking out resources to remain sheltered. In Grand Rapids, we've seen an increase in kind of all of these different categories: adults with children, adults without children, youth with children and without, and also children and unaccompanied. Looks like it's a really huge number. The N is very small there, but it's just an increase globally across all of these categories here in Kent County. I want to talk a little bit about assumptions about homelessness because there is a lot of, I think, stigma and false belief that kind of follow around patients who have homelessness, and it really impacts how they experience healthcare in general. So some of the most commonly believed reasons that people are homeless is that they have mental illness, which is driving their homeless state. And really, we think probably at most about a third have mental illness. There are beliefs that the majority of them are having substance use disorders. We think the number is probably somewhere between 20 and 40%, depending on different studies and self-reported models. Really, the truth is the majority of money isn't spent on substances. People who are in a situation of homelessness are usually spending money on things like hygiene products, food, and water. There's an assumption that there's a high rate of criminal activity, but those experiencing homelessness are more likely to be victims of violent crime than they are to commit violent crimes. The common reason that people believe people are experiencing homelessness is around bad choices. They've done something, they deserve to be homeless. They've made a bad choice along the way. But really, most homeless people prefer to have a job. They need to get a job. And a lot of people believe that they aren't part of the community, but the vast majority of people in any given area are actually from that community, have not relocated. So the assumption the person who's experiencing homelessness is responsible for their situation, and really it's a much bigger problem. The real origins of homelessness are around lack of affordable housing. This is just a shocking statistic for me. National Low Income Housing Coalition. There's no state in where a person earning the federal minimum wage can afford a 2-bedroom apartment at fair market value. Poverty, underemployment, unemployment, wage stagnation, limited availability of public assistance to help people who are in situations of need. The lack of affordable health care. People experience unexpected illness and the costs that come along with that. Family situations and changes, things like domestic violence, loss of a family member, divorce, and then natural disasters. So there are really complex social structures with roots in poverty and inequity that are causing homelessness, and it's not a result of bad choices. I want to highlight there are racial disparities in homelessness. So a larger proportion of people who identify as African American or Black compared to the number of people in Kent County are experiencing homelessness compared to our white community members. I'm going to slip back here to the Hispanic. The Hispanic and non-Hispanic, it follows more the number of people, the percentage of people that are in Kent County that are actually experiencing homelessness. And homelessness and health. People who are experiencing homelessness, research has shown that they're more likely to become ill, they're more likely to suffer from chronic illnesses, exposure-related illnesses, and those can be more severe. They often do have combined mental illness and substance abuse issues. And up to 30% we think probably have a substance use disorder. Even though they have increased need for access to care, they often have less access to care. They may need to prioritize food or shelter to spending money on healthcare or medications. They may have lack of access to healthy foods, hygiene, difficulty with transportation, no transportation, difficulty corresponding with their physicians, no phone, no address where our physicians can send information to them. And they are not uncommonly experiencing discrimination or trauma within the healthcare system. Okay, another question, you don't have to participate if you don't want to. How does the expected mortality of those experiencing homelessness compare to those not experiencing homelessness? It's about the same. Those experiencing homelessness have a life expectancy of about 10 years less, 20 years less, 30 years less. It's actually 30 years less. The average lifespan for those experiencing homelessness is that dramatically different from someone who's housed. And for unsheltered homeless individuals, the risk is up to 10 times as great. The highest mortality is seen in what we call the rough sleeping population, or people who are homeless but not sleeping in a shelter, sleeping in an encampment or out in the open air. And this was highlighted by a study that was done by Boston Healthcare. For the homeless program, they have a very robust and longstanding program. They probably are the best in the nation at providing care for those experiencing homelessness. They did a study back in 2000, and they followed 119 patients that they were taking care of that were homeless, and a third of those patients had died within 5 years. The leading causes of death were similar to the housed population, but it was a 3 to 6 times higher incidence than a general population, and they often had more severe disease as well. Healthcare utilization costs are much higher for those experiencing homelessness. And a lot of this is that there's reliance on emergency services, not access to primary care, increased rates of hospitalization for illnesses that are presenting in advanced or late stages as well. And all of these things kind of compound and make it more difficult for those experiencing homelessness to get care. So there's a lot of stigma with homelessness, a mark of disgrace associated with particular circumstance or quality, and this attribute that's deeply discrediting this belief that homeless people have deserved the situation that they're in. And the reality that we all have implicit bias, we have these automatic and unintentional beliefs that we don't control, but they can affect our judgment and how we behave in our society. And all of these things have resulted in a situation for homeless people that make it more difficult for them to get out of homelessness, to get the care that they need. Unfortunately, our society, homelessness has been really largely normalized. And in some circumstances, it's criminalized for loitering, not having access to bathroom facilities. And that makes it more difficult for the homeless to, even if they're engaging in programs to get out of that situation, to have employment and get access to the things they need to get out of that situation. I'm going to turn it over to Christa. She's going to talk about a lot of the work that we do here in Grand Rapids, along with Victoria.
Thank you. I think I just throw it on there. I have no problem being loud, but let me know if you can't hear me in the back. So I think as healthcare providers and as community members, we just faced a really big dilemma. We have an increasing number of people who were experiencing homelessness in the community, who are in the most need of care and who weren't able to get it. On the flip side, we as just a healthcare system, we're spending much more money on people who are experiencing homelessness for worse outcomes. So whatever we are doing to help provide healthcare for this population, just in traditional mainstream medicine, was just not working. And this dilemma is what started the birth of the street medicine movement. So street medicine aims to engage people experiencing homelessness where they are and on their terms to provide free, high-quality healthcare. In short, we go to the people. That's our motto in street medicine. By taking our services to the people, we aim to eliminate as many barriers as possible while facilitating positive encounters with compassionate doctors and medical students who are uniquely trained to the needs of this population. We hope that we are not only providing the necessary care that is desperately needed in this population, but we're also working to rebuild that trust with the healthcare system in the long term. Street medicine began as a movement by Dr. Jim Withers, my personal hero, on the streets of Pittsburgh, Pennsylvania in 1992. And since then has become this huge international movement. So this is not something we're doing in just Grand Rapids or just Detroit. It is a huge international movement. I think it is in like 15 different countries and across 5 continents. And the Street Medicine Institution as a whole kind of offers guidance and specified training for the concerns of people experiencing homelessness. That's us. Oh, sorry.
Alrighty. And I also just want to, there was originally a slide on this, but I just also want to take a second to talk about language surrounding people experiencing homelessness. So we like to say people experiencing homelessness or unhoused or unsheltered folks. There can be a little bit of nuance with that language, but we don't want to say like homeless people. And so this just gives a little bit of respect and more dignity to the person. They are not the identity of homelessness. So similar to, I feel like the popular movement was like diabetic people. We now say people with diabetes. It just takes the identity out of the diabetes for them. And same with this. So people experiencing homelessness, it takes their identity out of being homelessness and just become like, it's just a state, right? Like it's a temporary time that they're experiencing. So little side note, but important to make note of. So Grand Rapids Street Medicine. So we're going to get into the nitty gritty of our organization. So Grand Rapids Street Medicine, our mission is a multidisciplinary outreach team partnered with community resources that brings free and high quality healthcare to persons experiencing homelessness. And so really our vision for our organization is responding to the needs of the medically unserved to prevent the incidence and progression of disease and to bridge the gap between healthcare systems and vulnerable populations in our community. So basically, in less pretty language, we provide, our goal is to provide free healthcare to those experiencing homelessness or underserved kind of populations in our community and kind of fill in that space where these folks get kind of lost. So between our healthcare system, which they often do not traditionally fit within, and within, you know, just our community and, you know, giving them a voice and kind of a place to go for their healthcare. So our values, human dignity is a major one, and you will see over the course of Christa and I talking, and also Dr. Makowski talking, that human dignity is really key and core. Another one is effective use of healthcare resources, and I kind of will touch on this a little bit later, but we function on donations mostly. And so being able to creatively use our resources is really huge. Accountability for the members of our community. So hoping to educate and inform our community so that we can, advocate for folks that are unhoused. And then student engagement. It's a student organization. So this is huge. We want students to be part of this. We want you all as, pre-meds and undergraduates to be part of this. So a huge core value. Okay, so growth of Grand Rapids Street Medicine. I could talk about this all day. It's the coolest thing. So we have seen rapid growth, and it's a really, really beautiful thing. So kind of starting in late 2018, Dr. Makowski was on a rotation with med student at the time, Matthew Oram, and they were kind of discussing lack of student-run clinics within the Grand Rapids community. And it was chatted about how this had been tried, student-run clinics had been attempted, and it just never really succeeded. And so at this point, Dr. Makowski reached out to a good friend, Dr. Richard Bryce, who is in Detroit and runs a lot of the street medicine programs in Detroit. And he was able to kind of provide good insight on what that looks like and kind of what that means for serving the unhoused population. And so from there, they kind of developed a mission and kind of a path forward. And so reached out to community organizations to see what sort of the need looked like in the community. And Mel Trotter Ministries, which is the local homeless shelter in the area, was kind of the first to say, hey, we are also interested in kind of doing like some sort of medical clinic. And so they were our first community partner and established Grand Rapids Street Medicine. Shortly after that, we established what we call Community Partners Medical Clinic, which is housed within Mel Trotter Ministries as well. And this is a partnership where we have like obstetricians, chiropractors, dentists, nursing staff. So we have like all of these medical services housed at Mel Trotter, and we function as kind of a walk-in free clinic. And I think we are 4 days a week, and see folks all 4 days of the week for whatever medical service they need. So that's really awesome. So that was the establishment. And then around fall of 2019, Exodus Place, which what's the word I'm looking for? Transitional housing. Thank you. They help get unhoused folks, kind of find them jobs and things like that, and kind of get them back on their feet. They were also interested in partnering with us, but then simultaneously the COVID-19 pandemic happened. So obviously big unsettlement across the board. And so we were able to do telehealth with Exodus Place guests during this time, which was really awesome. So we provided medical care via telehealth during the COVID-19 pandemic. And then starting in fall 2021, we kind of had some fun changes within our Mel Trotter clinic, or the Community Partners Medical Clinic. And so we actually established a partnership with the Corwell Health Family Medicine Residency Program. And so those residents, as part of their rotations and their protocol to graduate, they actually come and work at the Mel Trotter Clinic, and they see our patients. And it's been really wonderful for kind of establishing that follow-up care for folks, because then they can kind of transition within the Corwell Health system and continue to get care. So that's been really awesome. And then we also had a clinic remodel at Mel Trotter, which is great. So we kind of function as a full, more what you would expect to see when you go to a doctor's office. And we have like point of care testing. So like quick tests that we can do, like lab tests that we can do on the spot. So that's been really cool. And then in 2022, we established another pop-up clinic, which is at St. Mark's Church. So St. Mark's has a breakfast once a month, and we go in and we provide medical care as well during this breakfast for unhoused folks. And then we partnered with a Christian Dental Association, which is kind of fun. They help do vitals and kind of help triage patients for us, which is just nice to have like more students learning and all of that. And then we're really proud. Through St. Mark's, we were able to get the Cook Foundation grant for $18,000 for medical supplies at this location. So that was a huge win for us. In 23, we started working with Catherine's Health Center, which provides like income-based medical care and then also free healthcare depending on income status. So we actually partner with them and we go to Crossroads Bible Church. And this is like a really neat day. It's on Tuesdays, and folks that like do haircuts come in. We have showers, we have breakfast, we have social services. So it's a real, and then our medical services now. So it's like a really neat environment to really help out folks and get them the sort of things that they need. And they also just redid their clinic space. Well, they didn't really have one. It's a church. So they created a clinic space. So again, kind of like a doctor's office. So that's been a really kind of fun thing for us as well. And then we also do a similar pop-up at Emmanuel Lutheran. And that recently started. So kind of the same, where there's breakfast and then we have some medical services. Okay, so successes. We are very proud. We now have 4 clinic locations, and this is kind of over the span, as you saw, since 2018. We treat about 50 patients per month, depending on our just flow into all of these sites. We have 15 attending physicians who help us run and guide our clinics and students and residents. So that's amazing. We have 275 medical students that volunteer with us through Michigan State. And then we also have 25 residents that also work with us through the family medicine residency program. And this is really cool because some of them have stayed in town as an attending. So they've now graduated from residency and are attendings, and now they're staffing our clinic as attending. So this is kind of a cool, beautiful thing. They have it reserved in their schedule to come to Maltrotter on Thursday. So that's been really awesome. We have started up data collection points for future research opportunities to kind of look at certain things that we're seeing. And then we're utilizing a donated Epic system build. So we actually got gifted Epic Systems, which is the electronic medical record that we use at Corewell. So Corewell gifted us this. So this was huge. So it really helps with our efficiency in our clinic. And then I kind of already talked about it. We've had 2 site remodels, but has also really helped with like efficiency and just comfort, honestly, for our patients. These are our community partners. This is like the slide we should pause on. This would not be possible without them. This is huge. Maltrotter has been mentioned. Corewell Health has been a huge partner, both in their residency clinic, just their work they've done for us with the Epic build. So huge pause to them. Also, like City of Grand Rapids, we work with the HOT teams, which is the homeless outreach team. It's part of the fire department. So they've been like a huge kind of support and advocate like out on the streets for us. So that's been really great. And then one thing I haven't mentioned yet, Oasis of Hope is just they also just see patients and such, but we go there, you know, like once a month and do just like patient education. It's just a good opportunity for students to have like more volunteer work and outreach. So we also go there, but huge shout out to our community partnerships. We really thank them. This is you.
So I know we talked a little bit about one of our core values in street medicine being going to the people. And going to the people has looked very different in each of our clinic settings. And so these are the 3 types of clinics that we have created just to be able to serve the people wherever they're at and however we can serve them. So the first clinic that we have is our classic community partners clinic. This is our clinic that exists inside of Maltrotter. It services the guests there who are interested in being seen, but anyone in the community is welcome to be seen as well. They do not need to be a guest there. This is the closest thing that we have to a standard doctor's office. It's that one in the top on the left, or the top, top left. That's how directions work. It just looks exactly like any doctor's office that you would attend. And we staff the clinic with physicians on one day, and then they also offer dental, optometry, mental health, chiropractics, as I know Victoria talked about. Our second type of clinic is our pop-up clinics. And at our pop-up clinics, we bring our supplies and we set up a makeshift clinic for a couple of hours. I think it's really essential for us that we purposely set up these, quote, pop-up clinics in well-established, well-known community events with community partners who are very familiar with this population, and that these events are already well known by people experiencing homelessness. So we go to things like the St. Mark's Community Breakfast, the Emmanuel Lutheran Community Breakfast, and Crossroads Bible Church, so that we can just be where all the things are happening, and so that we can offer healthcare services to whoever's just stopping by. A key factor with our pop-up clinics is that our goal is that we are taking all of our stuff with us at the end of the day, so that we are not burdening that community space with having to store our medical supplies or having to house a permanent clinic. It's something that can continue to be used by the community after we leave. And then lastly are our street runs, which we're hoping to start up with Catherine's Health Center in the next month. This is your very traditional street medicine. It is going to the people in its most basic forms, where we put on our backpacks and we go to encampments, under bridges, to wherever the people may be. This has been something that we have been working on for years, but we really wanted to make sure that we were intentional in starting this. We wanted to do our street rounds with the people who were well known and well trusted in the community. Because, I mean, if I were to walk up to your house with a backpack, walk into your house, it would probably freak you out a little bit. But if I came there and your friend texted you and said like, hey, I'm bringing a new friend over, and I walked in with them, you probably would feel slightly more at ease. We don't want to just insert ourselves into someone's living space and into their environment while just breaking trust, and it doesn't set up for a very good situation. You want to be my presser? Mm-hmm. Thank you. So we have all these clinic types, but what actually happens at clinic? We often describe the work that we do as a combination of an urgent care and a family medicine clinic. So at any one of our clinics, patients can have medications refilled. They can get wound care. They can get foot care. They can be seen for any acute illnesses or rashes. They can have any basic lab work done, strep, A1C, flu, COVID, pregnancy testing. And we also offer referrals for psychiatric care. These are our most common ones, but we can offer referrals for anything really. Something that is really important to us is that we run our clinic exactly how students expect. So our students will be in clinic and it'll run exactly like our primary academic centers. And this is so that they are not having to learn any additional type of structure. It is how our attending physicians are used to, and it maximizes learning and care for the patients. So our upperclassmen will always be paired with a lowerclassman, and we will bring a patient back to the room. We will do some vitals. We will take a second to ask the story of what's going on, ask some questions about their history, do an exam. And then those students will leave the room and they'll go to what we call staff with an attending physician. So they'll go and speak to the attending physician and they'll tell them the story of what's going on. And together that group will discuss what could be happening, what the different diagnoses are. And then the whole group, the attending physicians and the students, will go back and see the patient again together and determine a plan in collaboration with the patient that is going to work out for them and that is very respectful to the barriers that our patients are experiencing. I think a common one that we deal with, if anyone is familiar with diabetes or with insulin, I like audience participation, so I'm looking at all of you. What might be a problem with giving someone 6 months of insulin if they are living on the street in Michigan summer? I heard it. You have to refrigerate it. Yeah. So insulin has to be refrigerated for long term. So we are really conscientious of this, and either we will dispense insulin in small quantities or we will make sure that their insulin can be stored at one of our local shelters, or that they have a place where they know they're going to be able to store it. Something that we train all of our students to do is to practice what we call trauma-informed care, which acknowledges the long-lasting effects of traumatic experiences and the effects that they can have long after the trauma is gone. We are definitely not experts, Victoria and I, maybe Dr. Makowski, her more than us. But we feel it's really important for all people to kind of understand the basics of trauma-informed care. So here are some tips that we emphasize with our students to make sure that the care that they are emphasizing is trauma-informed. So our number one goal is to listen. I tell all of our students that 90% of what we're doing is listening, and 10% is actually practicing medicine. One of our biggest parts of this model is that we have medical students. So if you go into a traditional doctor's office, you may get 10 minutes with a physician. But our students have tons of time, and we have a lot of students. So on average, our visits last an hour, often an hour and a half, because students have that time, and our patients really appreciate having someone who's willing to listen to their story and listen to what's going on. Our goal is also to give patients autonomy and empower them to make their own choices so that when they're ready to engage in the healthcare system, we're there for them. We aim to create a safe environment. Patients are free to leave at any time. We have private spaces so that they are able to have a full, like in regular clinic, you can have privacy, but we are not holding anyone captive. We have had patients who just are not ready and they get up and leave in the middle of the appointment, and that is completely fine with us. We emphasize that none of our students should promise something that they cannot deliver. So we never make promises to our patients about things that we are unsure of or are out of our control. We're very honest, and we have that conversation with them. So I would never say like, yeah, I know you're going to get into housing next week if we don't know that to be an absolute fact. One thing that is really important to me as well is minimizing re-traumatization. So for our patients, this means that we're not asking about experiences that may trigger a trauma response if they are not relevant to our care. And honestly, in my 4 years of doing this, I can't think of a single time where knowing why someone was homeless was relevant to me providing care for them. It has been relevant for me to ask if they were out of the streets, because maybe my care might differ a little bit as opposed to in a shelter. But it has never been important for me to know why someone was homeless unless they volunteer that info for me. I think like a patient where this really came to mind was a couple of weeks ago. We had a gentleman at our community partners clinic who had been attacked by a group of teenagers because, as Dr. Makowski said previously, people who are experiencing homelessness are more likely to be the victims of violence than they are to commit violence. So we had a man who was attacked by just a group of local teenagers. His meds were stolen and his wheelchair was taken away. And this was told to us by one of our community partners before the appointment. He came in trying to get a wheelchair, trying to get his meds. I knew all of those things. And so there was no value in me asking, how'd you get that black eye? Or what happened? Where did all your meds go? It was just going to create more trauma for him and was nothing that was going to serve our visit at all. Something that is also really important to emphasize with our students is to have them recognize that trauma can manifest as a variety of maladaptive responses. So the response to trauma could be something like hostility or aggression or drug use that may have served that person at one time. It may have been what saved their life in one situation, but it currently is not serving them anymore when they are safe. I think the biggest one that I remember related to this was a case of our colleagues in Detroit. And there was a gentleman who everyone in the encampment lovingly called the skunk because he smelled. And so the street medicine team in Detroit, when they were telling us the story, they were like, we were so excited to be able to bring a shower to him so he could shower because we were sure he wanted to shower and he would want new clothes. And he didn't want to shower. He was like, no, this smell that everyone is so angry about or commenting about is what keeps people away from me so that I can stay safe. You want this one? I think this one. I lost my notes. So we have many options for follow-up care. But I think the main point that I wanted to emphasize is that we don't force any type of follow-up care. We really aim to empower patients to re-engage in the healthcare system when they're ready. So when that time comes, we have partnerships with the Corewell Family Health Medicine Residency Clinic, as we talked about. We can refer for any type of psychiatric service. We have a great relationship with the Center for Integrative Medicine, where we can set up same-day appointments for substance use disorder and harm reduction. Really anything that anyone is in need of, we can just make it happen and hopefully connect them. If we can't, do something with a community partner who is going to be able to do that as well. Thank you. And it is not just our patients who are benefiting, it is our students as well. So I always joke that the hidden agenda of street medicine is to create an army of advocates. Our goal is that we are creating the next generation of physicians who is going to be compassionate advocates for this population. Our street med students are going to be the emergency room doctors. They're going to be the surgeons. They're going to be the OBGYNs that are seeing these patients in the hospital and are in a position to navigate what barriers that person might have to just getting the best care that they can, and also stop that cycle of having medical mistrust and negative interactions with the healthcare system. Oh, wait, go back for a moment. Our students also learn a lot about compassionate care, definitely, from the upperclassmen and from residents and attending, but most importantly, from our patients. I think our medical students will 100% agree that we can teach people all the classroom learning they want, but until you are able to interact with someone who is actually experiencing systemic injustice, or actually talk to someone who is dealing with substance abuse disorder, all that book learning doesn't matter. No, I'm good. Now you can have it.
Yikes. Okay. So just to talk a little bit about my thoughts and experience with street medicine. So I think, as we talked about at the beginning, I think a lot about dignity when working with this population, and dignity in the sense that this is often a population that is sadly dehumanized. People walk by them, they don't make eye contact, they are ignored. And, when you think about it within the medical sphere, I think that we like to have a nice, perfectly square box within medicine. And if you don't fit inside and you can't fit the mold, then that's it. You don't deserve care. And you're not going to get it. And so I think what we've done here is really special. I think sometimes it doesn't seem like we're doing something crazy. We're going in, we're seeing a patient, but it means a lot. Our ability to listen and our ability to see these patients and to provide them with medical options and give them back their autonomy is valuing their life. It is valuing their life through healthcare and giving them back the ability to be seen and to be respected. And so I think this has been the most powerful part of street medicine for me. And, something that I use every day when seeing patients outside of just street medicine. And so another thing Christa touched about that I've learned a lot about is just being creative with our resources and being creative with your medical care. So she talked about, for example, a patient who has diabetes, who needs insulin that needs to be refrigerated. And how do you think about creatively about these obstacles you may encounter to provide the best care you can? Because I think, again, to the effect that medicine is a square, we have these systems, we have these protocols, but oftentimes, again, our care doesn't fit in these protocols. We have to make changes and have to learn how to do that. So I think it's really valuable in that way as well. And then lastly, just like the power of community resources, like just the fact that you all are here tonight, like you understand something that many people don't, and you now have a powerful tool. And so, like in my work now, like this past month, I just spent doing emergency medicine in our community. And first of all, I love emergency medicine because the door is open to everyone. It's never closed. And so we do see a lot of unhoused folks. And like this past month, we've made these like nice resources of where housing and clinics are. And I was able to hand them out to our unhoused folks and just say like, hey, there's some options for you when you leave here. And I think like that's powerful, right? Like you give people a choice of where to go and a resource that they have. And also it's been really meaningful because I have made sure I've told every attending I've worked with, I'm like, also, I'm going to print these out for you so that you now have them. But this is how we like learn and grow, and we share our resources and we provide opportunities for folks who otherwise wouldn't have them. So I think just like know that wherever you go, learn your community resources. It's like a powerful, powerful thing.
I think for both Victoria and I, street medicine has been the most defining experience of our medical school career. We could sit here and talk to you guys for hours about the patients that have impacted our care, that have changed the way that we practice, and who have just won our hearts over. I think street medicine in general has taught me that kindness and compassion really do matter to our patients, and that it does create meaningful differences in care. I think street medicine has challenged me to be able to advocate for my patients and to try to challenge myself to be the advocate that they deserve. And I think something that has been a real eye-opener for me is that as a future physician, I have been given an extraordinarily large amount of privilege in this community. And that it is really my job to take that privilege and use that to uplift the voices of those who are most often silenced and forgotten in our community. Our community is definitely telling us what they need. We just have to be willing to listen. And I love this quote at the bottom. It's something that is very famous in street medicine and really encompasses what I strive for when I continue my practice in the future. You want to say something?
Yeah, so we just we had a really wonderful year, and I guess we're blessed by our partnerships. And so this was just some press that we've gotten this year and some interviews that we've done. So you can check us out online if you want to read more. And then we also were part of I think Michigan's first ever street medicine conference in Detroit this year. So that was really cool. It basically had all of the universities, so like University of Michigan, Western, Spartan, like Michigan State has different branches of street medicine as well at the different sites. So it was just a chance to collaborate and hear what other folks are doing and kind of build, figure out what works and what doesn't work and make our care better.
There you go. So if you listen to this whole hour-long presentation and you were like, this is so great, but I don't have a medical degree and I can't write prescriptions, that is completely okay. Neither can I technically for a couple more months. There is still so much that you guys can do. Something as simple as, like Victoria emphasized before, using person-first language, educating yourself and acknowledging what your biases are when you see someone on the street. Speak with your vote and be aware how proposed laws might criminalize homelessness, especially when it comes to things like parks, litter, trash, and what might be interpreted as trash or litter in laws. If you ever get the opportunity to vote, street medicine is cheap. So if you ever get an opportunity to, vote for street medicine or support an initiative, this is more for our faculty who get to vote to support initiatives that encourage street medicine. You can practice trauma-informed care in your everyday life. We also just encourage people to acknowledge people who are experiencing homelessness as literally just humans. So it costs nothing to make eye contact with someone and smile and wave. I have small self-care kits in my car that if someone is in need of them, or like little snack bags that I'm like, hey, if I see someone at a stoplight or something, I can stop by and say, hey, do you need anything? I have a bag of stuff with me. Is there anything that you could use in here? Or give them the whole bag. Can also donate your time and stuff. We love stuff. We are donation based only. You can donate unused medical supplies, unopened self-care supplies. We love those little hotel soaps that you get. We use them every single clinic. And also just if you see this list and you're like, this is so great, I want to help and I don't know how, please just reach out to us. If we don't have something that you can directly help out with, we will definitely get you in touch with a community partner who could use your help. Next one.
Thank you.
Thank you guys for being here. Thanks for having us. Questions? So the question is, if we are not providing housing, who in our community is? The question that you're asking is essentially regarding, should we prioritize housing, which is very fair. I want to break it down into two different parts. One, we recognize that, especially in street medicine, health is a human right. And regardless on if you are ready to pursue housing, not everyone wants to pursue housing. Some people really do prefer, just based on their experiences, the trauma that they hold, or just what they're dealing with at the moment, don't want to be in a house. We've had tons of patients like that. And for those patients, they still deserve care. They deserve care in this moment until they're ready to engage back with housing or ready to engage back into the system. Anyone want to add anything to that?
I would just add that when we started thinking about forming this group on the behalf of students and then for our community members who were needing healthcare and facing homelessness, we fully acknowledged that we couldn't solve the problem of homelessness. And there are organizations in our community like Mel Trotter, their mission is to eliminate homelessness.
Yeah.
But from the experiences that I had as a physician and in the space that I worked and the influence and power that I had in my work, and the goals of students, we could do something very positive to influence health. And so that's why we really, when we started looking at doing this, we wanted to partner with other organizations that were bringing something to the community of those experiencing homelessness. But we've always acknowledged that our role isn't to end homelessness. We don't have that skill set. Our skill set is something different.
What does the process of the site referrals look like for patients?
You want to answer a question? So we have a partnership. For example, if this were to happen in our Mel Trotter clinic, we can literally put in a referral. And just down the hallway, yep, they could go to wherever they would like to. We do have a partnership with Catherine's Medical Center for mental health care. And just down the hallway from us is usually a therapist and another practitioner who are running mental health services. So one, if I had a question about a referral or I had a question about when this patient could be seen, I can just walk down the hallway and ask them. And then usually the referral, if they would like to go with Catherine's Health Center, we can just set them up for an appointment at Mel Trotter in the clinic the next week.
I think you had a question about that. Related question. It is with regard to the systemic issues, even with community partners and in that there's a lot of people who you can only like see these providers or access this particular. Do you feel like this those things?
Oh, yeah, thank you. So question is, do we feel we should advocate for more like systemic healthcare issues, such as signing folks up for Medicaid or Medicare, and kind of what that looks like in terms of locking folks into certain providers and plans? So I guess folks at Trotter do register people for Medicaid and Medicare if they qualify. That's something that they do there. And then again, with Catherine's health clinic, it's income based. So
Go ahead.
they, can see providers within that system. I think it's a great question. And I think, kind of as Dr. Makowski said, we only have certain skill set and certain resources, honestly, to be able to do so much. But I think the important part, I guess, for me is that these folks get healthcare. I do hear what you're saying. It will lock them into certain, systems and certain providers, but I think it's a stepping point just in receiving care. And I think that's a huge step. And then we can tackle like secondary things. I think it's a great question and a great thought. But I think like it's just important that these folks get care initially. As you saw, like the ramifications of not receiving care are significant in their lifespan. So I think it's really important to get that initially.
Yeah, I think one of the things that this organization is able to do is give us a lot of information and a platform for making change on a bigger scale in the future. So if we are seeing patients and we have data and outcomes that talks about avoidance of costly care in the ER because people are able to access care where they're staying, I can take this back to the leadership team that I work at Corewell and say, like, this is actually a business case to provide care in a different way that meets the needs of patients who need something different. So I think it gives us a really powerful place to start to build something different in the future. It gives us a foundation to make it easier for patients to get care, because then I can go and say, like, look at what we're doing here. How do we get patients the care that they need? There is cost savings in this. Taking care of patients saves a system money. And that's really, really important in the way that kind of business is working in healthcare right now. So we don't have all the solutions for it, but I think it really helps that larger conversation going forward. Yeah. Mark.
Yep. So online question, do you have any statistics on the LGBTQ plus homelessness?
Oh yeah, talk about Moaddel. That whole bed.
I don't have the statistics off the top of my head. I regret that we did not put it in the slideshow.
Mhm.
Are you familiar?
Yeah.
We can let you know that this is something that is really important to one of our community partners, though. Again, this is not something that we are doing in a vacuum. We are doing this with many community partners who are also collaborating and working in this space. So one of our shelter partners, Trotter, actually has a designated space now for individuals who identify as trans or non-binary and do not feel comfortable in traditional men's housing or men's shelters. I think they are definitely the first one in Michigan.
First in the country.
First in the country.
They
There you
might
go.
be
I was
the
like, it was a
only-
really big deal.
They might be the only one in the country still. I don't know of any others that have developed this.
Yeah. So that was super huge for us. And we support everything they're doing. They're fantastic. We love our Trotter community partners.
What is the most common illness that you see among your patients?
Exactly what you would see at a regular clinic. Just not without proper management because they're unable to get it. Hypertension, diabetes, allergies, asthma, chronic pain. However, it often is unmanaged or is very symptomatic because they just aren't able to get the care that they need. I will repeat the question. So from these pop-up clinics, can they get blankets and can they get other things as well? So one, at our pop-up clinics, we have some wonderful undergrads and our street medicine organization in general hands out self-care products because we think that that's essential to health. So we hand out condoms, we hand out toothbrushes, toothpaste, soaps, Band-Aid, whatever someone may need, as well as a variety of over-the-counter medications if it's something that they need for their condition. But this is where that big factor of having other community partners comes into play. We are not the best people to offer clothing. So we don't offer clothing because we have some really amazing community partners who do that really, really well. We have not engaged in handing out blankets because that's something that we have other community partners who do really, really well, and that's their specialty. So the question was if we've ever had someone abuse our services or what was the second half?
Yeah,
Taking advantage of the situation or taking advantage of our services when they didn't need it. I cannot, in my entire street med experience, think of a single time where this has happened. In fact, I have definitely even had patients say, I don't need these services as bad as so-and-so does. Can you see them first?
I would add to that too, that a lot of the care that we provide is a lot like urgent care and it's kind of like primary care, but I often describe it as transitional primary care because we're really trying to get patients into the standard medical system if that's a good fit for them. We do have patients that for whatever reason are not going to engage in the standard medical community or can't. And so then we kind of become like their primary care and meet their needs to the best of our ability and the resources that we have. But I also have never had an experience where I felt like there was inappropriate utilization because we're really built to help people if they can't engage in another way. We're open to working with them in that situation. Yeah. Yep, the question was whether or not Epic connects to Care Everywhere, and the answer is yes. Yes. And that was one of the reasons I could guilt people into gifting that to us, because there really is an advantage. If somebody hasn't been engaging in standard medical care and they show up, we don't know their history. We might not have any information about them. And so it makes it much easier for an ER or a different primary care office or a specialty provider to provide care if they're starting with some information to go in. So.
Yeah.
I couldn't hear that part.
Can they see our clinic notes? Yes, they can.
Yes. Yep. We can see other clinics notes.
Oh, they can see our notes.
They can see ours. We can see yours. Mark.
Is there a way for undergrad students to become involved, such as volunteering in clinics?
Yes. To repeat the question.
GRCC Health and GVSU Health students help as well.
Great question. Can GRCC and GVSU health students help as well? Yes. Probably not in the way that you're thinking, but yes, we would love any help. There is always a need for more people who are passionate about street medicine. We already work with some undergrads who help us a lot with handing out supplies, who help us with putting together self-care kits and getting donations for us. I am going to be completely honest because I feel like we do have a lot of pre-med students who approach us and are like, I'm an EMT. Can I have my ENT skills? And unfortunately, we have a certain type of liability. Essentially, our attending physicians are extending their liability and their malpractice coverage to us. And they're only allowed to do that to medical students who are at MSU CHM. So any type of really health care, even if it's taking vitals, even if it's just taking a blood glucose, is something that malpractice won't cover if you're not a CHM student. So unfortunately, we don't recognize other licensures outside of our GRSM ones.
Final question.
So in regards to your patients, chronic pain, you refer them to like pain specialists, pain management specialists, and then do you have any partnerships with them, and like local PTs, so that that's the way they can be treated before just asking them for pain medication.
So the question was, if someone is coming in for chronic pain, do we have a way to treat them before we, just hand them out pain medication? So we actually do not hand out pain medication at our clinic. Just so that was really clear from the first start. We actually do a lot of referrals for PT, wherever's going to be the easiest for that patient to reach. Does anyone want to add something on? And then we can refer to anyone, any pain management specialist. If they're interested in something in particular, we definitely can. We often refer for people who are struggling with the issues with pain medication to the Integrative Center for Integrative Medicine. Yes. We don't have any PTs. Are you inviting yourself? Because we're interested. Because we're interested. That's a great idea. It's something that honestly, we just haven't explored. We refer to PTs and we make sure that it's something that isn't covered by their insurance and that they are able to access. That's part of our process. But no, we haven't thought of bringing PTs along with us. That's a great idea.
I would ask that you all thank Dr. Makowski, Victoria, and Christa for the presentation tonight. And just want to thank you all for attending. Want to thank our sponsors, our co-sponsors, Michigan State University College of Human Medicine, Grand Rapids Community College, and Grand Valley State University. And I want to thank our friends at Grand Valley for again hosting this year. Thanks for coming. Good night.
And then I'm gonna